patients. Is there any question? Okay. Okay, so let me continue. So this patient had hypertension prior to pregnancy. So we're talking about 20 weeks. So before this patient had pregnancy, before this patient became pregnant, less than 20 weeks, this patient already had hypertension, elevated blood pressure greater than 140/90, right? Patient can be asymptomatic, right? Can be asymptomatic, can be on medications basically. And so, of course, the other risk factors, the risk factors for hypertension will come into play here. So diabetes, obesity, lifestyle changes, alcohol, these are things that can increase the risk of having chronic hypertension. And I define chronic hypertension as a patient who has an elevated blood pressure of greater than 140/90 before the 20th week, or rather before the conception of pregnancy. And so this is not most commonly tested often. It's just given as an alternative or option variable when you're answering questions. These are the main things, right? Gestational hypertension basically is that you're saying that a patient has this blood pressure of 140/90. So has that blood pressure of greater than 90/140. And then this patient noticed, so your doctor, the patient comes to you for the first time you're seeing this patient is above 20 weeks, comes with a blood pressure of this. Patient is non-proteinuric. So there's no proteinuria in this patient, right? Right? There's no proteinuria in this patient, but this patient is just hypertensive. So the patient is just hypertensive. There's no proteinuria. There's no end organ damage, but this patient was noticed to have hypertension, sustained elevated blood pressure of greater than 140/90. And the first time you checked that patient, it was greater than 20 weeks in a non-proteinuric. So this woman was not proteinuric or hypertensive previously. So this is the first time you're seeing this patient. This patient did not have any history of hypertension in the past, had no history of proteinuria in the past, right? You're seeing this patient for the first time. Blood pressure is elevated, no end organ damage. Patient is not proteinuric currently, right? Now, in preeclampsia basically is this guy here, the definition of was 20 weeks parallel. So basically, for the steps, they use 20 weeks, right? For the step one, they use 20 weeks. In different countries have their own cutoff points for you to define it as hypertension. But for the step one, which is the exam you're going to partake in, their cutoff is 20 weeks. That's why I use it. It's not something that I defined, yeah. And so preeclampsia basically is this patient has gestational hypertension, right? The patient has 140/90, right? Greater than 20 weeks. Then this patient now has plus proteinuria. You don't need to know the amount. It's not tested in the exam. You don't need to know if it's 4 grams or whatever, greater than 4. No, you don't need to know that. What you do need to know for the exam is that the patient has sustained elevated blood pressure and the patient is proteinuric for the first time in pregnancy, greater than 20 weeks. And the patient prior to this pregnancy never had any hypertensive episodes, right? That's it. And so risk factors for gestational hypertension, of course, there are many of them. One of the commonest risk factors for it is primary gravida. The patient is primary gravida or nulliparity. That's one risk factor. And of course, other chronic medical conditions such as chronic kidney disease, diabetes, all these things are things that will increase the risk factor of having hypertension. Also, you can have a patient with molar pregnancy, and I mentioned that in the last class that the patient with molar pregnancy, for some reasons, tend to have an increased risk of having gestational hypertension. But here's the funny thing. For molar pregnancy, the onset, usually, molar pregnancy is one of the causes of hypertension in a patient that was never proteinuric or hypertensive, and the patient presents in less than 20 weeks. So what am I saying here? I am saying that a patient who came to you, the patient has hypertension, less than 20 weeks. But prior to when the patient got pregnant, the patient was not hypertensive. The patient was not proteinuric, right? But less than 20 weeks, the patient is now hypertensive. You see the patient is not hypertensive, but prior to that pregnancy, the patient was not hypertensive. If you want to query any cause, I think you should do an ultrasound scan to confirm that this patient does not have a molar pregnancy. Let me repeat that again. The patient comes to you less than 20 weeks, having hypertension. But before then, before the patient got pregnant, the patient was not hypertensive. The patient has been normal all throughout his life, or her life rather. And then within the first 20 weeks of pregnancy, this patient is discovered to have hypertension. One of the commonest causes that you would want to screen for is molar pregnancy. That's what I'm just trying to say. And so, what is the pathophysiology of preeclampsia basically? So, what happens basically is that we have a blood vessel. So, we have the villi. So, this is the spiral artery. So what we have always known about preeclampsia, I'm drawing this so that I can explain what basically happens in preeclampsia, right? So what we have always known is that there are certain cells here, they call them extravillous trophoblasts or extravillous cells. So what happens basically is that these extravillous cells, like they are lining this space here, more like the lacuna, right? The lacuna. So these are extravillous cells, extravillous, they're outside the chorion, right? Extravillous cells. And these trophoblastic cells, which are they're also part of the trophoblast, basically, what they do in normal pregnancy is that they would invade this spiral artery. So they will invade the spiral artery here. The essence of invading this spiral artery is to ensure that this spiral artery becomes change. There's a change in the what do I put it now? Change in the constituent of this artery. So basically, normally you have the thicker part of the artery known as the media, right? So what this thing does basically is that it invades the media of the spiral artery, making the spiral artery more vasodilated. And the reason why it's making it more vasodilated is that because the pregnancy, you need a lot of blood to go into this lacuna space so that the placenta can take the blood, right, and give to the fetus. That is why you want these spiral arteries to be invaded. So these cells, basically, these extravillous cells, basically, what they do is that they invade the media of the artery, basically, of the spiral artery, and they cause vasodilation. That's what they are supposed to do in normal pregnancy. And the vasodilation is meant to take a lot of blood from the maternal circulation down to this canal and the fetus and to the placenta. That is what is normally supposed to happen in pregnancy. But unfortunately, what happens here is that there's a defective invasion, meaning that these cells would line the lacuna, but they don't invade the spiral artery. And of course, within the first 2 months of pregnancy, this is not supposed to be a problem because the blood that's coming from the spiral artery and going to this lacuna space is enough for the small embryo here that's growing. But what happens when pregnancy goes on? Of course, the placenta becomes bigger, meaning it needs more blood supply. The child needs more blood supply, and what's not happening? The child needs more blood supply, but these spiral arteries are not vasodilating, and so what we have here is what we call placenta hypoperfusion. So there'll be placenta hypoperfusion. And that's bad for the placenta because the placenta is not just only a nutritious organ. It serves endocrine functions and inflammatory functions as well. It helps to produce cytokines, right? If the placenta is not well perfused, it leads to ischemia. And of course, when there's ischemia, there's inflammation as well. And when there's inflammation, basically all the inflammatory cells are recruited, and most of the cells will secrete these cytokines along with the placenta. And what this causes basically is that it causes a widespread vasospasm of almost all the arteries in the body. And this further worsens the ischemia. So basically what you have here is that the placenta is not properly perfused. Placenta is not properly perfused. It undergoes ischemia. While it's undergoing ischemia, this ischemia doesn't mean it's generalized, just a certain region of the placenta that is not getting a lot of blood, right? The arteries don't get blood. And then what happens? This ischemia leads to inflammation. Inflammatory cells are recruited. Chemokines are secreted. What does these chemokines do? They go out of the body, cause a lot of vasoconstrictive and ischemic effects on the whole body. And that is just basically the pathophysiology of preeclampsia. And the bad part of this basically is that because a lot of cytokines are released, a lot of vessels are injured. A lot of vessels are caught up in this whole scenario, and a lot of them are damaged. More inflammatory process goes on, but it has a peculiarity for vessels of the brain and vessels of the gut. It has a very strong peculiarity for vessels of the brain and vessels of the gut. And so that is why the last spectrum of preeclampsia is eclampsia, because what happens? You are having that vasospasm, that ischemic vasospasm in blood vessels of the brain. And of course, you know that the brain is one particular region that needs a lot of, a lot of oxygen, a lot of oxygen and a lot of blood supply. Hence, this patient, the woman will present with seizures, and so eclampsia basically is a patient having preeclampsia plus seizures. And so what you do basically is that you give a drug known as magnesium sulfate to them. The mechanism behind giving magnesium sulfate is that it's a membrane stabilizer. That is one. That's the first mechanism. The second mechanism is that it has vasodilatory effects. I told you that one of the basic pathophysiological mechanisms in preeclampsia is that there's vasospasm. And so when you give magnesium sulfate, basically, you cause vasodilation of these arteries, which is what is normally supposed to happen, right? And it also stabilizes the membrane, so the woman doesn't continue having that eclamptic seizures that she's having. And so there are some certain drugs that you give to patients to control their blood pressure in pregnancy. Very common one. They're very useful. We have hydralazine. We have alpha methyl dopa. We have labetalol. And we have nifedipine. These are the 4 drugs that we give to pregnant women. Labetalol and hydralazine are IV, and so they are used in emergent processes. So these are IV medications, and so you give them to the patient when the patient is not able to tolerate orally, is having a seizure, right? And that's basically that about it, right? So what do you do if the patient has the eclampsia? The definitive management basically for all this pregnancy hypertensive disorders in pregnancy is delivery of the fetus. So you have to deliver the fetus. Why are you delivering the fetus? Basically because the culprit in all of this is the placenta. So once the placenta goes, the pathophysiology the pathology is kind of like eradicated a bit. But I know you guys will be wondering, because even after delivering the placenta, a woman can still convulse after delivery, right? She can still convulse after delivery. Why is that basically? So basically, the brain, the blood vessels in the brain are the last blood vessels to kind of like have that vasodilatory vasodilatory effect of magnesium sulfate. So the blood vessels in the brain are the last ones to get the vasodilatory effect of magnesium sulfate. And so even after administering it, even after delivering the placenta, some of those cytokines are still present in the maternal bloodstream. That is one reason. The second reason is that the blood vessels in the brain recover very slowly to preeclamptic effect. So I want you guys to know that's just by the side, okay?
You said in preeclamptic effect. Do you have seizure or convulsion in preeclamptic effect? Because I know that doesn't is
Yeah,
not manifestation in preeclampsia.
yeah. I'm sorry, I meant eclamptic effect. Sorry, I was trying to relate it like eclamptic effect. Sorry. So the
So
blood
sorry.
vessels.
Again, another
Okay.
question. I apologize for cutting in.
Yeah.
You, I didn't understand the dysfunction of the spiral vessels when you were explaining it. I mean, the cause of preeclampsia for pregnant women. Could you take it
Okay.
again one last time, please? Thank you.
Okay. So there are cells of the trophoblast known as extravilous cells of the trophoblast. Of course, the trophoblast is what forms the placenta, right? And so these extravilous cells come from the placenta and then evade this spiral artery. What do they do basically is that they turn this. First of all, you need to know that the placenta is a low pressure system. It's not a high pressure system, right? That's the first thing by the side. Now, these cells, these extravilous cells from the trophoblast, they come to the spiral artery. When they come to the spiral artery, what is supposed to happen in normal pregnancy is that these cells would invade the media of the spiral artery. The media is the strongest part of an artery. The media is where the muscular layer is, that's like the strongest part of the artery, right? And what they do when they invade the media is that they try to make the arteries more tortuous. They make it more tortuous, they make it more open, so that blood leaves the maternal circulation and goes to the placenta. But what you have in preeclampsia basically is that the extravilous cells, they get to the spiral artery, but they don't evade the spiral artery. They don't invade the media of the spiral artery. And so initially in pregnancy, during the first, like, let's say 12 weeks, the fetus is small, the placenta is small. The vasodilation is meant to allow a lot of blood to get to the placenta so that the placenta is properly perfused, right? And then it carries out its basic function, neuroendocrine function, nutrition, and all that. But what happens here is that these cells come, they don't invade this artery, and this change does not happen. So there's no vasodilation. So the arteries become the way they are, like they maintain the same caliber. That is actually good within the first 12 weeks because why? The supply and demand chain is equal. There's no need for too much blood in that lacuna space for the placenta to take. But what happens is that as the pregnancy goes on, the placenta becomes bigger, the surface area becomes larger, the fetus becomes bigger. And so the spiral arteries, because they did not vasodilate, they are not able to give out a lot of blood to meet the demand of the placenta, or rather, the demand of the placenta, basically. They can't meet up with that demand, right? They can't supply that demand. That demand that the placenta is now growing, it's gotten to a stage where it needs so much. And so some part of the placenta will be hypoperfused. And so the placenta is a neuroendocrine organ, basically. So it helps with secreting hormones that are very, very important for the fetus. It also helps with blood modulation. It also helps with nutrition. So basically what happens here is that when the placenta is injured, it will release cytokines because, of course, when there's no blood supply, ischemia happens. Ischemia happens to the placenta, but it's not every part of the placenta. It depends on how severe it is. So if the placenta is a very large placenta, and that's why one thing you see with patients who have preeclampsia is that when you deliver them, the placenta is shrunken a bit because of the ischemia. It's hypoperfused. It's not growing as it's supposed to grow. The reason why is because this ischemia leads to inflammation. Now, the placenta is releasing a lot of cytokines, inflammatory cytokines. Now, these inflammatory cytokines will go into the spiral artery and go into the maternal circulation. And what this thing would do is that it will cause widespread vasospasm. So almost all the blood vessels in the brain are being exposed to this wide surge of cytokines in the maternal circulation. It goes to the brain, goes to the kidneys. These are places where it goes to because it has some kind of like trophism for these organs. And that is why eclampsia is a spectrum, is the last spectrum of the, is the last part of the spectrum, because the brain, the blood vessels of the brain, once they are affected, they tend to be more severe, they cause more severe problems, and the road to recovery is quite slower. And that is why when the vasospasm, the ischemic, the blood endothelial dysfunction, the endothelial injuries happen to the blood vessels in the brain, it takes so long for the brain to recover. And in that time, the brain needs blood supply, it needs oxygen. When you cut that off from the brain starts to dysfunction, and then the patient presents with seizures. So, and I said that the only way to help this situation basically is to control the blood pressure, which is a temporary fix. Give magnesium sulfate, which is a membrane stabilizer and also a vasodilator. So the vasodilator goes there, does the function of this trophoblasts, the estrofilious trophoblast cells, dilates all the blood vessels. Hence, the ischemia is reduced a bit, right? And then it also helps with the brain, so that the brain doesn't, when the brain convulses for so much, it's firing so much, it's firing everywhere. So magnesium sulfate goes there, binds to the calcium receptors there, also helps to kind of like slow the brain down. Yeah. So that's what basically happens. And so the definitive thing is to remove the placenta. I now said, even when you remove the placenta, the patient can still have an eclamptic seizure. And the reason why the patient can have an eclamptic seizure is because of two things. The first thing is that, one, the cytokines that are causing this vasospasm and injury to the blood vessels are still present in the maternal circulation for a long time, basically. And thus, the second reason I mentioned is that the brain, the blood vessels of the brain, it takes slower time for them to recover from that insult. And of course, you know what that means. It means that the patient can still convulse subsequently, right? If there's a brain injury. So that's what I was just trying to say there.
Thank you.
Yeah. Okay. So there are other things you need to know that are not so high yield. I'll just talk about them. Yeah. I talked about the superior hypotensive syndrome. So basically what happens here is that the mother, okay, we have someone that wants to ask a question. Yeah, Kingsley, go ahead, ask your question. Kingsley.
The proteinuria in preeclampsia, how does it come about?
So basically, like I said, all the blood vessels, okay, let's put it like this. Do you agree that the glomeruli is a blood vessel?
Yes,
Yeah,
in
so
the kidney.
exactly. So I told you that the cytokines that are being released basically have a trophism. They have so much love for two organs, basically, the brain and the kidneys. And so they affect the blood vessels to these organs. And so, of course, if these organs are not functioning, one of the first things, which is the glomeruli, is part of it, basically. When there's injury to those blood vessels, proteins leak, right? So it's a vascular injury that causes a lot of products to kind of like leave the glomerulus, basically. Ideally, proteins are not supposed to leave the glomerulus because they are very large in size. So it goes to tell you how significant preeclampsia is, because for the kidneys to start, filtering out protein in urine, it shows that the injuries, the cytokine induced injuries, are really, really significant. I don't know if that makes sense.
Not yet. I think, I don't know. I'm just trying to picture the whole stuff because
So
there's
when
no vasodilation going on in the glomerulus. I don't know. I just want to be more clear about the whole pathophysiology.
Okay, so what you need to know about why the kidneys are significantly injured is because the cytokines that are released, they do two things. The first thing is that some of them have vasoconstrictive effects, just like what you have when you have inflammation, basically. right? Some of them have vasoconstrictive effects, right? That's the first one. The second one is that when you have a surge of cytokines, it attracts inflammatory cells, and so there is endothelial dysfunction because of that. Of course, that inflammation going on, inflammatory cells are coming in, and when inflammatory cells come in, they release certain, cytokines. They also release a lot of enzymes that can, in one way or the other, affect the blood vessels, right? And so basically, what it does is the blood vessels are injured, and I told you that the glomeruli is an example of a blood vessel, right? The renal artery brings blood to the kidneys, and so those blood vessels, of course, endothelin, yeah. And so these particular um, blood vessels are injured because of not only the inflammatory cytokines that are released, such as thromboxane and endothelin and the likes, but also because of the fact that these cytokines also bring inflammatory cells to that place. Once there's a widespread vasospasm and injury to the endothelium, inflammatory cells come there. It's the same pathophysiology that you have for plaques formation, basically. The same pathophysiology. The endothelium is disrupted, there's kind of like stasis. You want to repair that endothelium that's injured. Cells come in, release inflammatory cytokines, release inflammatory enzymes, and these things cause, of course, more damages. The problem is that for a brief period of time, if those things act on the blood vessels, it's supposed to cause repair. But you know that one of the basic problems we have, one of the sequelae of chronic inflammation is injury to that organ itself. I don't know if it makes sense to you.
Yes. I now get it. Thank you.
Yeah. Okay. So we have the other one that we talk about, the supine hypotensive syndrome. This basically just means, just simple from the word. So ideally, this is one of the reasons. This is because of this supine hypotensive syndrome that we tell pregnant women to lie by their side. So basically, during pregnancy, there's volume expansion, right? Volume expansion. So it means that the blood is a lot more lighter. Expansion, the blood is a lot more lighter, and so there's an increase in preload to the heart. So of course, you know that if the blood is thicker, preload, there will be resistance to blood going to the heart. So what basically happens here is, this is the uterus of the pregnant woman, right? So this is the uterus, and this is the inferior vena cava, right? And so if the woman lies on her back, that uterus, gravid uterus, can compress the inferior vena cava, right? It can compress the inferior vena cava. And when this woman abruptly stands, when you stand abruptly, the blood pressure drops a bit. Now imagine if this patient lied like this for over 2 hours. You can just imagine what will happen. The preload will drop, and if the preload drops, what happens? The stroke volume drops. And if the stroke volume drops, the PP will drop. So that is the idea behind supine hypotensive syndrome. Basically, you have reduced blood to the heart because the uterus is lying directly on the inferior vena cava. I want you to know that the inferior vena cava and the aorta is also lying side by side. But the reason why this patient does not have reduced blood supply to the leg is because the aorta arteries are quite stronger than veins rather, right? And so any small external pressure, because of how the veins are made, they are capacitant vessels, they store a lot of blood. And because external pressure reduces the lumen of the veins, and hence it drops the preload. And I don't know if you guys are aware, I think the inferior vena cava is the largest vein in the body. I don't know. I think I read it somewhere when I was much younger. And so just imagine you are taking about, let's say, 50% of the blood volume, you are keeping it in the legs. The patient will have symptoms of hypotension, dizziness, and the likes. And that's why we always tell pregnant women to lie by their lateral side so that the pressure of the uterus doesn't come directly on the inferior vena cava. Okay. Now, the next thing we're going to talk about is the tumors, the epidemiology of the tumors. This is quite easy to remember. In terms of commonness, it's I think it's EOC, meaning the one that is commoner. So endometrial tumor is more common, ovarian followed by ovarian, followed by cervical. And then when you reverse this, as you have CEO, so this one has the best prognosis, followed by this, followed by this. So cervical, no, what am I saying? That's not what I'm saying, sorry. That's not what I'm saying. Okay, so basically what you have here is that, yes, cervical has the best prognosis. So cervical has the best prognosis, followed by endometrium, followed by ovarian. So ovarian has the worst prognosis, right? And endometrial cancer is the most commonest. So you can just put it in that way to put it. They don't really test that in the exam though. It's just for you to just have that, extra knowledge. They don't test that in the exam. But what they do test is this next topic we want to talk about, the vulvar pathologies. And so we have the neoplastic and the non-neoplastic. The non-neoplastic has three pathologies basically associated with it. And so we have the Bartholin cyst or abscess. So can anyone tell me what structure gives rise to the Bartholin gland? Embryologically, what structure gives rise to the Bartholin gland?
Urogenital sinus, right?
Yes. So I mentioned in the last class that anything that has to do with the urogenital sinus gives rise to the glands. So you have the Cowper's gland, you have the prostatic gland in the males, that arises from the urogenital sinus. Then you have the Bartholin's gland in the females, and you have the gland of skin in the females. All of them, these four glands. Anytime you see gland in a question, a way to remember it is that the glands are gotten from the urogenital sinus. Very easy to remember. And so what you have here is that the Bartholin gland has a duct that releases the secretion to the exterior, right? It's located around the labia minora, and so it releases secretions, basically, right? These secretions help with lubrication during sexual intercourse. So if there is a blockade of this duct, you're going to have a Bartholin cyst, basically. You're going to have a Bartholin cyst. And if that cyst becomes infected, you have a Bartholin abscess. And how you manage this is that you do what we call a marsupialization. So if this is the Bartholin's gland is inflamed and is enlarged, or it's a cyst, you cut the gland, and then you oppose these edges to the skin here. And why are you doing this? You're doing this because if you close it, if after you have drained and you close it, the secretions can reaccumulate and it can lead back to a reoccurrence. And so you do what we call marsupialization. So you make an incision over the gland, and then you oppose the flaps to the skin here. You do the same thing here so that it can just drain out, and then that's how you manage it. What they usually do in the exam is that they would give you a picture. They don't have a picture here. I would have shown you guys if there was a picture here. Okay, yeah, there's a picture here. So they will put this for you guys in the exam, and they will ask you guys what's the diagnosis. Patient presents with pain pain, swelling of that region, and then they will ask you guys what the most likely diagnosis is. So it's very important for you guys to know that. Now, the next thing we're going to talk about is the leaching sclerosis. This is also very high yield. Right? Leaching sclerosis. Anytime you see the word leachinification, leaching and leachinification is gotten from the same term, which means thickening. thickening of the skin, and that is something that is characteristics of this disorder, right? Sclerosis means sclerosis,
Fibrosis.
fibrosis, of course, yes, fibrosis. So fibrosis. So what you have here in lichen sclerosis basically is that you have on the vulva here, you have a thickening of this vulva region here. And this thickening is as a result of an inflammatory condition. Well, we don't really know the exact pathophysiology behind it, but for some patients, they have a progressive inflammatory condition that leads to significant pruritus. I think that's the word you would see in a question that kind of like gives it away. And it's usually found in women who are peri or postmenopausal or prepubertal. And what happens here basically is that you have the vulva. So the thickening doesn't just stay at the vulva. It can extend downward to the anus, and it can give this figure of 8. So let me just draw it so you can understand what I mean by this figure of 8, right? So let's assume that this is the, so it's not really neoplastic, it's more inflammatory. So let's say this is the vulva, right? We have the urethra here, we have the vagina here, and we have the anus here. And so what you have here is that there'll be thickening of this place, thickening of this place, thickening of this place, thickening of this place, thickening. All these regions here are thickened. And you can see it's giving this kind of like 8, like this number. It's giving it like, because there's extensive thickening of that region there. So all this region you're seeing here are thickened, right? Are thickened basically. So you have to know the demographics and the presenting complaint. They usually tell you that there's intense pruritus. This is what gives it away basically. Now what happens again basically is that when there is thickening of the introitus here, when there's thickening of this introitus here, you have a thickening here. So there's thickening here, there's thickening here, there's thickening here. It reduces the lumen of this introitus. The introitus cannot stretch because that place is elastic in a way. It's meant to be elastic, it's supposed to stretch so that the penis is able to enter without resistance. But when there is fibrosis and sclerosis, it narrows the lumen. So when you're having sex, when the woman is having sex, she'll be having discomfort because the skin around this region cannot stretch and it causes significant pain. Likewise, what you have here in the anus, there's also reduction in the lumen. There's also reduction in the lumen. And so when the patient wants to pass out feces, the lumen is reduced and the patient will have pain because the lumen of the anus can't stretch as well. So not stretchy. And so this patient presents with other secondary symptoms such as dyschexia and dyspareunia, right? And this condition increases the risk of squamous cell carcinoma of the vulva, which is what we're going to talk about in the next topic. For lichen sclerosis, it's a different thing here. So it's not inflammatory, but what gives this away in the exam is this leathery. So it's leathering, like in texture. When you see it, it's like a leather. Like it has this rubber-like appearance, right? Rubber-like appearance. And it's due to hyperplasia of the squamous, the vulvar squamous epithelium. So this is also very high yield for you to know. The difference between this guy and this guy is that in this guy, the itching is not as severe. And this guy has other secondary symptoms such as dyschexia, dyspareunia, and the legs. This guy is inflammatory. This guy is not inflammatory, right? The last difference between these two is that this lichen sclerosis increases the risk of squamous cell carcinoma, and this guy doesn't, right? And then we're going to go to vulvar carcinoma. We have two etiologies. We have the etiology that's the result of, we classify them according to a virus known as HPV. So we have the HPV cause of vulvar carcinoma, and then we have the non-HPV causes. The non-HPV causes includes leaching sclerosis, like I mentioned earlier on. And then the HPV cause is caused by two viruses. We have 16 and 18. These are high risk strain, so it's very important for you to know this strain, right? The one that causes genital warts. Can you guys tell me the ones that causes genital warts? The strain of HPV that causes genital warts.
16.
16.
Yeah, 16. Yeah, so 6 and 16. Yeah. So it's very important you guys should know that, right? So basically, this is how vulvar carcinoma looks like. It can look like an ulcer, it can look like a swelling, it can look basically more like this with rough edges, well delineated rough edges. Can have things like this. Sometimes it can present as a wound that doesn't heal, right? It's very, very common, right? The next thing we're going to talk about is the extra mammary Paget disease. So this is Paget disease, but it's not occurring in the breast. When we get to the breast, we'll talk about that as well. But what you just need to know basically is that it's a carcinoma in situ. So it's not an invasive carcinoma, right? It's a carcinoma in situ. And you can see that it has a low risk of becoming a carcinoma as against Paget's disease of the breast, which is always associated. When we get to the breast, you understand the difference. The key word I want you guys to know here that is that intraepithelial carcinoma. Intraepithelial. It's within the epithelial cells. Basically, that's what they're trying to say. And you can see this is basically what it is. This, you can see it here. This thing you're seeing here. Like I said, he gave a very good diagram of this, right? Okay. Do we have any questions here? Okay, so let's move on. We're going to talk about perforate hymen, right? Imperforate hymen. So basically, what happens here, basically? Let me explain what happens in perforate hymen so you can understand the pathophysiology. So early on in development of the female, the paramesonephric duct, these two ducts here, forms, the paramesonephric duct comes together to fuse to form the uterus, the uterus, the fallopian tube, the uterus. So this is the uterus, the fallopian tube, and then the upper part of the cervix and vagina. So it forms this part. So the upper part, this part here. Now, another structure known as the urogenital sinus comes and forms the lower part of this part here. Right? And so what is supposed to happen is that this membrane that is formed between the paramesonephric duct derivatives and the urogenital sinus derivative is supposed to be resorbed or degenerate. This is supposed to form the hymen, basically. And so what happens here is that this hymen does not degenerate. And so the patient presents with imperforate hymen. How do you know imperforate hymen? It's very high yield in the exam. It comes out a lot in the exam. I don't know why they love it, but it comes out a lot. How does a doctor know if a patient has imperforate hymen? So when you do an examination, you see a bulging bluish membrane, usually a girl child, and the patient will have what we call amenorrhea. So the patient will have more like a primary amenorrhea, right? Primary amenorrhea. So they'll tell you that the child has not menstruated since attaining puberty. When you do an examination, you see a bluish bulging. These two words are key in the exam. Bluish and bulging membrane. What do we call this word? Bluish and bulging membrane. What's another name for this word? Bluish and bulging membrane. What's another word? Another name for it?
Hematocolpus.
Yes, hematocolpus, exactly. So that's what you see on the membrane. When you see that it's imperforate hymen until proven otherwise. And so how do you manage it? You do surgery. You don't reset the whole hymen. What you do what we call a cruciate incision. So you do something like this, and then it opens and the blood comes out. So you just do a cruciate incision on the hymen. You take the patient to the OR, you do a cruciate incision, and then the hymen, kind of like comes out, right? I don't know. Do we have any questions about that? Are there any questions?
Kindly recap the pathophysiology of imperforate hymen, just the pathophysiology.
So, what is the other name? The other name of, okay, the other name she was talking about is hematocorpus. Okay, so what I was trying to say basically in imperforate hymen is that the paramesomorphic dot forms the fallopian tube, the cervix, and the upper part of the vagina. And then the lower part of the vagina is gotten from the urogenital sinus, basically. I was not trying to say that these two parts fuse together. They develop independently and then fuse together. And then the membrane between both of them is supposed to degenerate, which forms the hymen, basically, supposed to degenerate. Or some part of it is supposed to be resolved. Let me use this word. Some part of it, maybe the central part, is supposed to be resolved so that menses flows out. But what happens basically is that this central part is not resolved, and so it's not resolved basically. The cells here the central part do not degenerate, and so you have a closed membrane basically. So blood can't come out, and so the patient every menstrual cycle we have blood gathering in this region here. So there'll be gathering of blood here, and then it will be pushing this membrane downward. This membrane you're seeing here, pushing the hymen downward basically. And that's what you see in imperforate hymen. Okay, I hope that's understood.
Yeah, thank you.
So we're going to talk about vaginal tumors. I think vaginal tumors basically, the most commonest one we have is, or rather a very common tumor that we have is squamous cell carcinoma of the vagina. It's usually secondary. So it's secondary to cervical squamous cell carcinoma, right? And the reason why is because the transformation junction just below it is the ectocervix, right? And then that ectocervix is lined by squamous cells. So it's only logical for the cervical squamous cell carcinoma to involve the vagina, right? But these two are the ones that are very high yield for the exams. And so this clear cell carcinoma is the one I want you guys to remember, right? Now, what happens basically is that the vagina, when I was talking about the histology of the vagina, I was talking about the vagina having what we call non-keratinized squamous cell, right? Non-keratinized squamous cell. And so the proximal vagina has this non-keratinized squamous cell. And I explained why, the reason, like the logical reason behind it. So what happens in vaginal clear cell carcinoma is that the patient is exposed to this compound called the mother rather is exposed to this compound, diethylstilbestrol, which is more like an estrogen form of contraception, basically. And what this drug does is that when it crosses over to the baby, crosses through the placenta and gets to the baby, it causes this proximal vagina that is meant to be squamous, it makes it more columnar and secretory. So this drug basically causes a form of let's say metaplasia. No, I shouldn't say metaplasia. So it causes this proximal vagina, instead of becoming squamous, which is what you find in the adult, it becomes columnar. So there's a persistence of the columnar epithelium in this upper part of the vagina, right? Over time, the babies, there's supposed to be metaplasia in this region here. That means it's columnar epithelium because it's derived from more of the upper part of the vagina. the paramesonephric duct, which primordially has a columnar epithelium. So the dye is still best of all passes through the mother, through the placenta, gets to the baby, causes that metaplasia to not happen. So columnar is supposed to change to squamous, but that doesn't happen. And so the patient presents with this clear cell carcinoma. It's a tumor that's commoner in newborns, right? And it's due to this drug exposure. This is very high yield for you to know for the exam. Okay. Sarcoma botryoidis is also another very high yield tumor. And just to highlight, it's an embryonal tumor, and most tumors that arise from the mesoderm tend to have desmin as their tumor marker. So you can be given a question where they will show you the presentation of the fetus, or sometimes they might not give you the picture. They might just tell you the presentation that the child, 4-year-old child, was born, had a normal delivery. On examination of the fetus, the introitus had grape-like polypoid mass emerging from the vagina, and they might ask you, okay, what is the diagnosis? That's the first way they can put the question. The second way they can put the question is that, okay, the tumor that causes this condition in this patient expresses which of the following tumor markers? You might put S100, they might put GFAP, they can put any neuroendocrine substance, and then they will put desmin. So you need to know. So these are ways they can go around the question, just for you to just have an idea of it, right? Okay, so I don't know if that makes sense, guys. Does that make sense at all?
Yes, it does.
Yeah. So that thing is the high yield thing. What causes it, right? You need to know the tumor marker. That is the very high yield part of it. And then you need to know the presentation. Sometimes they might not give you the presentation. They might just give you a picture showing you a baby or a girl. You know, you look at the vagina, you're seeing grapes. I know you guys, like, you know how grape looks like, right? That kind of thing is originating from the vagina. And they might just ask you what's the diagnosis, or they might just ask you the tumor expresses which of the following tumor markers, and they might just list that. So it's very high yield for the exam, especially for step 1. In MBME 27, I think there's a question on it. MBME 27, there's a question on sarcoma botryoidis, right? And the next thing we're going to talk about is anovulation. So anovulation, what happens here in anovulation basically is that the patient does not ovulate. Now, in the menstrual cycle, basically, what happens in the menstrual cycle basically is that there is an LH surge. So ideally, estrogen is supposed to cause follicular recruitment. So under the influence of estrogen, there's supposed to be follicular recruitment and maturation. Follicular maturation, basically. So estrogen is what causes the development of Figrafian follicle. So estrogen causes the maturation of Figrafian follicle, right? But this hormone here, progesterone, is what causes the other phase, which is the luteal phase. You know, progesterone causes, although LH is the major, is the LH surge that leads to ovulation, basically. But progesterone is also implicated in the rupturing of this follicle to release the mature ovum, right? And so what happens here is that in an ovulation, the patient does not ovulate. So the follicles just keep on maturing, and they don't ovulate, they don't rupture, right? And so here, what you basically have is that there is unopposed. So anything that will cause unopposed estrogen action would lead to anovulation. Anovulation, basically. So you can have PCOS, hyperprolactinemia, all the rest, right? Those are things that are very common to cause anovulation, infertility. It's just something I want you guys to just know by the side, right? And one of the causes we're going to talk about is polycystic ovarian syndrome. So this is very, 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 very high yield. Very, very, very high yield. I cannot emphasize what basically happens. It's the same thing that happens in anovulation. So this patient has anovulation. There's a criteria that you use to diagnose it. Does anyone know the name of that criteria? What's the name of that criteria?
Rotterdam.
Rotterdam criteria. Excellent. So you just need 2 out of the 3 to make a diagnosis, right? And the criteria, can you tell me the 3 criteria there? What's the first one? What's the first criteria?
On the ultrasound scan, you're asking?
No, there are 3 of them. There are 3 criteria of the Rotterdam's criteria. There are 3 components of the Rotterdam's criteria. Does anybody know?
I know about the on sonographic images, we find the subcentimetric cysts which are peripherally arranged, and the
Yes.
dense internal stroma, and the
Yes.
size of the ovaries gets enlarged too. The
Yes.
enlargement, the subcentimetric cysts which are peripherally arranged in a string of pearl
String of
appearance.
appearance. Yes.
Yes, and the third thing is the increased dense stroma. These
Yes.
3 things, when we find on the ultrasound, then we will say it's a PCOS.
Okay. So the criteria, thank you, Doc. That's what we find mostly on the ultrasound scan. But the criteria basically involves 3 things. The first criteria is that there must be an ultrasound evidence of enlarged cystic ovaries. The second criteria is there's oligomenorrhea, which can be anovulation, anovulatory cycle, right? And then there's hyperandrogenism, right? These are the 3 criteria. The criteria is saying that you need just 2 to make a diagnosis. You need just 2 to make a diagnosis. That's what the criteria is trying to say. And so this patient presents with a myriad of symptoms. Myriad of symptoms. They have irregular menstrual period. You know, they can't get pregnant. They are at risk of having metabolic syndrome, right? And also diabetes mellitus. These are other associations you need to know. It's commonly tested in the exam. So these things I'm saying are very important. What basically happens here is that there is unopposed estrogen action. And so the follicles mature and become cystic. They don't rupture, they just mature and become cystic. And that's why you have that string of pearl appearance. And then because there's so much unopposed estrogen, the endometrial lining becomes very thick. The problem with the endometrial lining is that you need progesterone to stabilize it, but there is no progesterone. And so this endometrial lining, they shed unscheduled. So they shed at very odd times or uncoordinated pattern, right? And so one thing that you need to know for the exam, and it's something I've noticed they have tested, I think this is in MBME 26. So they draw a patient, they'll draw the neck of a patient, and they'll put a hyperpigmented lesion on the patient's neck. Can anybody tell me what a hyperpigmented lesion is?
Acanthosis nigricans.
Exactly. So they will put it in the question, they will put that diagram, and they will ask you, which of these following conditions is this lesion associated with? They might write different things, and then they might write PCOS. So I want you to know that PCOS is also associated with this disease condition. And you need to know that because of the unopposed estrogen effect, this patient are at risk of having endometrial cancer. And so one of the drugs you want to give this patient, one of the ways you want to treat this patient is that you want to use OCPs. You want to use OCPs to kind of like modulate their cycle, you know, because the progesterone will now stabilize the endometrium, and then this patient can have a normal menstruation. Another thing you want to do that's very helpful and can help with fertility is that you want to reduce a lot of weight. You want to reduce their weight, right? You want to reduce their weight because for some very weird reasons, when somebody has a very large amount of fat, that fat has certain enzymes that can help convert androgens to estrogen. And one of those enzymes is aromatase. So the more fat a woman is, the more likely she's going to have one of the estrogen's derivatives, right? And so losing weight would try and cut off the estrogen supply to the body. Okay. Do you have any questions here before we move on?
Yeah. For the polycystic ovarian syndrome, is there any role for metformin?
Yes. So metformin is used, right? It's more of step 2 stuff though. It's more of step 2 stuff. They ask you for the exam? Not really. But just for you, just because you know you want to know, because one of the pathophysiological mechanisms implicated in it, like I mentioned, is obesity and metabolic syndrome, right? And also these patients are also at risk of what do you call it now? Diabetes mellitus. And so metformin also helps with the glucose control, because of course you know that patients who are fat, they kind of like are able to convert the glucose, excessive glucose in the body, to fat cells, right? And you need insulin to do that basically. And so for patients who are diabetic, they don't have that process. That process is not functional. And so you want to give metformin to these patients because they are also at risk of glucose intolerance because of obesity. Obesity is a risk factor for glucose intolerance. So giving them metformin is also very, very helpful.
Okay. The last question. For the two treatments you talked about based on step 1, you said weight loss, and which one again?
So you can give weight loss, all right? You can give OCPs. These ones are the ones that are commonly tested in the exams, right? Weight loss, like I said, you are trying to cut down the supply of estrogen, because when you have fat cells, you have more aromatase, and aromatase converts the testosterone to estrogen derivatives basically. And so you want to try and reduce that.
Okay, but what if the patient wants to conceive? Do you want to give the patient OCP?
No, you won't give the patient OCPs. You give them drugs that will help with fertility. And so you give them a drug known as clomiphene citrate. Yes. And what that does is that it helps with ovulation. It enables the patients to ovulate. One of the reasons why these patients can't get pregnant is that they can't ovulate. So if you can't ovulate, there is no mature egg for the sperm to fertilize, basically. So the clomiphene citrates you give them helps with that. Now, you want to be careful with giving them clomiphene citrate, because there's something known as, there's a disease condition known as ovarian hyperstimulation syndrome, which is very, very much common with patients that use clomiphene citrate. And so you want to be very, very careful if you're giving them clomiphene citrate. But however, clomiphene citrate is a drug that can also be used if they want to get pregnant.
Okay, thank you.
Yeah. So
Excuse me, Dr. OS, in the PCOS, the main issue for the high level of the estrogen, is it is it because of obesity or the adipose tissue only, which is making the estrogen from the aromatization of the androgens?
there are several. Those are many. Those are several reasons why the estrogen is elevated. But
So one
basically,
is that one. Yeah, one is that one. And what are the other reasons why the
so
estrogens is?
basically, the gonadotropins. There's an imbalance in the gonadotropins that are being produced. You know, the gonadotropins, we have LH and FSH. Yeah. So basically, what happens is that there is more LH than FSH, right? And FSH is the hormone that causes the granulosa cells to produce a lot of estrogens, right? So both of them are quite elevated in these patients. And so the FSH will stimulate the the granulosa cells,
Granular cells. Yes.
exactly, form estrogen. The LH will stimulate the T-card cells to produce androgens for the patient. But the problem is that when you are producing androgens for these patients, the androgen is being converted to estrogen because the patient has fat, basically. So invariably, you are just feeding the patient more resources to make more estrogen. Do you understand what I'm trying to say?
Yes, yes, got it. And the other thing is the LH level is much more high.
Higher,
If we
yes,
take
yes,
the ratio of both LH and the FSH, so we know that the LH get rise much more as compared
higher,
to FSH.
yes, yes, yes. I
So
agree.
that's why there will be the high level of androgens, which are
Yes,
causing the increased synthesis of testosterone. That's why there
yes,
will be the hirsutism.
yes,
That's
yes,
it.
yes.
Thank
You're
thank
correct. Okay, someone said I should summarize vaginal and vulva. Oh my God, I have to go over this again. Um. Okay, so let me see the question. Yeah, did someone ask a question? Okay, so usually they have high testosterone. Testosterone is way higher than estrogen. Testosterone is way higher. In fact, one of the tests you can do in patients with I think it's more of a step 2 stuff. One of the tests you can do for patients with PCOS is to check the testosterone level. It's more, well, let's say it's more specific than estrogen. I think, yeah, it's more specific than estrogen. So if you are to do one test apart from the FSH and LH level, you have to do one additional test to increase your high index of suspicion for patients with PCOS. In step 2, they will tell you to do more of testosterone than estrogen, right? That's just by the way. So I mentioned the side effect of clomiphene citrate. I mentioned one. It causes ovarian hyperstimulation syndrome. It's step 2 stuff. It's not something I feel you should bother yourself with. But you can read it up though. It's step 2 stuff. I will not really bother you with that information. Okay, so let me go on, and I want to explain vulva and vaginal cancer to this guy again. So I was talking about vulva lesions, and I mentioned that there are 2 types. I mentioned that for the vulva, we have the neoplastic and the non-neoplastic. For the neoplastic, for the non-neoplastic, I talked about the Bartholin cyst. I explained what happens there. I also explained the other 2 conditions, the leaching sclerosis and then the leaching chronicus simplex, right? And I explained that both of them, I explained the difference between both of them, right? I said that the leaching sclerosis is an inflammatory condition basically that is marked by severe pruritus. And the reason why the patient has severe pruritus basically is because it's inflammatory, right? It's inflammatory, the patient is itching, and then the vulva becomes sclerosed, becomes fibrosed, thickened. What this does basically to the patient is that it reduces the lumens of the vagina and then the anus. And then what you see because of that reduction is known as a figure 8 sign, basically. And so the patient will have dyschexia because let me draw this so that I can explain what I was trying to say. Hey, this is what I was trying. Okay, leaching sclerosis. So what I was trying to say by leaching sclerosis is you would have inflammatory conditions. It's an chronic inflammatory condition. That's what I want you to know. Inflammatory. And so it's marked by severe itching. Sometimes it can even ulcerate in some cases. Right? There's erythema, there's inflammation in that region there, inflammatory condition. So what you basically have here is that if this is the vulva, right? This is the vulva. This is the urethra. This is the vagina. And this is the anus here. So there is thickening of this wall here. There's thickening of this wall here. Thickening. In severe cases, so this is what you have. There's thickening. So all this place is thickening. It gives you this 8 sign. And the last thing I mentioned about it is that it increases the risk of squamous cell carcinoma. That's what I said. And when I was talking about vulvar cancer, I mentioned the 2 types. We have the non-HPV causes of vulvar carcinoma, and then we have the HPV causes. And that's why I talked about leaching sclerosis. Leaching sclerosis causes the non-HPV causes of vulvar carcinoma. And then I talked about the HPV, the strain 16 and 18 are the commonest strain that causes vulvar carcinoma. And then for the vaginal lesions, I talked about, okay, yeah. The last one I didn't talk about is apart from the vaginal carcinoma, I mentioned the mammary Paget's disease. And I said that the first thing you should note about it is that it's an intraepithelial adenocarcinoma. So tumor cells with low risk of malignancy invade the epithelium around the vulva. And so this patient presents with something that is similar to Paget's disease, but it's not Paget's disease, because Paget's disease is already a carcinoma on its own. It's already has a high risk of malignancy on its own, right? This one, on the other hand, has a low risk of malignancy because it is a carcinoma in situ. It has not passed the basement membrane. That's what I'm just trying to say. Okay, I don't know if that explains everything about that. Okay, so let's move on and see what we can do. And so we've talked about the PCOS, right? And I explained about why weight loss is important. OCPs is also important. And then ovulation and all that. Then these are drugs that you can use to treat the excessive hair. You can know either of them, but spironolactone is most commonly tested. For females, spironolactone is a drug that is most commonly tested in the steps. So it's very important you guys should know this drug because it can be used as a diuretic, right? In management of heart failure, and it can also be used to treat hirsutism, right? And one of the side effects of this drug is that it causes gynecomastia. So they can put in a question about a patient who is on spironolactone, and they might ask you what possible side effects of that drug, what's the side effect of that drug? And so I want you to remember gynecomastia, right? And now we're going to talk about these lesions, right? So I'm going to talk about premature ovarian failure. So basically what you have in premature ovarian failure is that for some very weird reasons, could be genetic, could be acquired, could be genetic causes, could be acquired causes, the patient has a very large depletion of ovaries. Now, the ovaries are the ones that produce estrogen, right? And so basically what you have in premature ovarian failure, this thing is that premature ovarian failure is that the patient is having symptoms of menopause. So the patient has symptoms of menopause, right? So the patient might have hot flashes, infertility, mood changes, vaginal dryness, and all of that. So the patient is having symptoms of menopause, but the patient is less than 40 years. So causes of this can be radiation, right? Can be chemotherapy, radiation, chemotherapy, chemo, right? Genetic conditions such as Fragile X syndrome. If it affects a female, can cause this. So, but most commonly it affects males. And it's one of those trinucleotide repeat disorders. And the mnemonics to remember this is CGG, congenital giant gonads, CGG. This is the tri-repeat nucleotide that is affected in Fragile X syndrome. And so these patients are usually male that have large ears, large testicles. And one very important thing you must know, so large testes, so large gonads. So that's where the congenital giant gonad comes from, because they have large testes. And then they have large ears. The most important thing I want you guys to remember from this is that it's the second cause of intellectual disability. The second cause, second to only Down syndrome, right? Second to only Down syndrome. So that's just by the way, right? Just digressing, I'm sorry. And so what you have basically is that estrogen is not produced. If estrogen is not produced, what happens? The body senses that, oh, this estrogen is not produced. Could it be that we're not producing a lot of gonadotropins? And what does the body do? The body now produces a lot of gonadotropins. FSH and LH is increased, right? That's what you have in premature ovarian failure. You should note that it's less than 40 years, not less than 35, not less than 45, less than 40, please. This age is high yield because this is what differentiates it from menopause. Okay. So it's also known as primary ovarian insufficiency. You just need to know this. So functional hypothalamic amenorrhea, basically, let's talk about it because it's also very high yield. So what you have in functional hypothalamic amenorrhea is that the patient is usually has severe calorie restriction. So it's found in athletes, female athletes, or generally, I don't know, even women who are present here. You notice that when you are reading for a very serious exam, such as a step 1, or you are reading for your university exam or college exam, you notice that those times you don't eat so well. You notice that sometimes there might be a delay in your period, or it might not be irregular, or something like that, basically. So what happens here is that severe caloric restriction causes what we call a change in the pattern of the gonadotropin releasing hormone secretion. So what happens here is that the gonadotropin hormone, when it's released, it's released in pulses. So this is how it goes. So it goes like this. This is how it's released. This is how it's released. So there are pulses, like it goes high, it comes down, it goes high, it comes down. This is how it's supposed to be released, right? This is how it's supposed to be released. And this pattern changes. So the severe caloric restriction causes a change in this pattern. And what that does is that it drops the level of FSH. Right? It drops the level of FSH and LH. And so estrogen is not produced. And then this patient has amenorrhea. The patient won't be able to see the period and all of that. It's commonly tested. They usually just ask, they usually in the question, they might not put that the patient has severe caloric restriction. What they usually do in the step 1 is that they would put the BMI of the patient. They'll tell you that, oh, the BMI of the patient is less than maybe 17. And then they'll tell you that the patient has been having amenorrhea, right? And then they will ask you what's the most likely diagnosis, right? So another mechanism that has been postulated is that leptin 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 is secreted by which nucleus in the hypothalamus? Leptin. Can anyone tell me what nucleus in the hypothalamus secretes leptin?
Lateral.
Lateral. I think it's lateral. Not too sure.
Are you sure it's not ventromedial? Are you sure it's not ventromedial?
Lateral.
It's lateral, okay. So it has been postulated in patients with functional amenorrhea that there's an increase in this hormone, right? And when this hormone is increased, right? Or is it increased? What am I saying? Let me see that. Yeah, so sorry. Okay, sorry, got that wrong. So one of the pathophysiological mechanisms that's behind this is that cortisol is reduced. Leptin, what's the function of leptin? Can anyone tell me?
It makes you hungry. It makes you hunger. So you eat when there is increased level of leptin.
Okay.
No, opposite. I think is satiety hormone. When leptin increase, that means you don't want to eat. Like satiety.
Ghrelin makes you hungry.
Ghrelin makes you.
Yeah.
So
So ghrelin makes you hungry.
Leptin reduces appetite.
Yes. So it reduces appetite. So so what happens here is that
And also leptin release from the medial hypothalamus, medial part of the hypothalamus.
medial. Here I was asking, I knew that it was ventromedial. I'm not sure it's lateral. I think the lateral is ghrelin it releases. I wasn't sure. So that's
you're
why
right. Ghrelin is for lateral. And,
yes. I was
leptin
asking, I
is
wanted to be sure. That's why I was asking. So ventromedial is the one that releases leptin, right? And so
Okay.
what basically happens is that leptin makes you satiated, meaning it makes you filled up. You're okay, right? So it's postulated that one of the pathophysiological mechanisms behind functional hypothalamic amenorrhea is that leptin is reduced and cortisol is increased. And you know, cortisol is a metabolic hormone. It's not anabolic, it's catabolic. And catabolism means that it helps to break down a lot of things, break down fats and all of that, right? Coupled with the fact that leptin is kind of like reduced. And we said that the function of leptin is that leptin makes you satiated and there's a decreased level. So it means that you're supposed to eat more. You're supposed to be eating more, but the patient doesn't eat more. Patient doesn't eat more, right? And the reason why leptin is reduced basically is that the patient has lost fat because of the cortisol. So the patient has excessive cortisol because of a stressful period, and then the cortisol breaks down all the fats, and then you have a reduction in leptin. So the pathophysiology basically is pathophysiology is that exercise leads to increased cortisol, which is a catabolic hormone. You know, it does the same function of growth hormone basically for fat and the likes. And this cortisol helps to break down lipids. And leptin is also produced by fat cells. So if there's a drop in lipids, it means that there's a drop in leptin as well. I don't know if it's clear, guys. So that's what happens. So this patient presents with osteoporosis. Why? Because estrogen is not there. Estrogen is what gives the bone its density. Estrogen prevents the osteoclast from degrading the bone minerals, right? And so when there's reduced estrogen, the patient is at risk of osteoporosis, right? What you just have to do for these patients, there's no particular drug you give the patient. You just encourage the patient to eat more, to have a more balanced diet and reduce stress. And then the patient's level of estrogen comes back. Now, we're going to talk about cervical carcinoma and whatever. Anytime you see dysplasia means a disorganized epithelium. And then carcinoma in situ means it has a potential of becoming cancerous, but it has not left the basement membrane. And so cervical cancer is more common in the transformation zone, right? In the basal layer of the transformation zone, and it extends outwardly. So let me explain what I'm trying to say. So basically, this is what I'm trying to say here. So then you need to know that this is a squamous cell carcinoma. That's the first thing. It's squamous cells that are affected, right? So basically, what we have here is that this is the basal layer of the epithelium, and then the cells are growing here. This like, and it gets to this basement membrane here. So if it crosses this basement membrane, it's an invasive carcinoma. If it remains, it's a carcinoma in situ. And so for the cervical carcinoma in situ, it has the same risk factors as this guy here, which is number one, HPV. Just by the side, HPV is the commonest sexually transmitted infection in the world. True or false? HPV. True, correct. So it's the commonest sexually transmitted infection. And HPV infected cells are known as coliocytes. So first of all, we know that the strongest risk factor to getting this cancer is HPV, the high risk strain. The second one is early coital. So patient has early use of early sexual experience. And then the last risk factor is the patient's failure to use barrier contraception. These are the 3 high yield risk factors you need to know for the step 1. And so choliocytes are cells that are infected by HPV. But before we do that, HPV causes inhibition of certain suppressor genes, and it depends on the strain. So HPV 16 affects this guy here called TP53. It affects this gene called E6 gene. E6 gene. That helps in the production of this guy. This guy is a tumor suppressor gene. So this gene here, upregulates this guy here. And this guy prevents the cells from having malignant potential. But what HPV does is that HPV 16 especially blocks this gene. And so there's no upregulation of this guy here. Thus, the patient comes down with cervical cancer. On the other hand, this guy here, HPV 18, what HPV 18 does is that HPV 18 blocks this guy here, E7. So it blocks this guy here, E7. And this E7 causes the upregulation of the retinoblastoma gene. The thing is that these 2 genes are tumor suppressor genes. So their function is to suppress mitogenic potentials of cells. So if they are blocked, the cells will undergo mitosis, basically. That's what just happens. And so the patient will present with postmenopausal bleeding. The patient will have, if in worst cases, the patient might have, what do you call it now? And usually the bleeding for cervical cancer is usually after sex. So it's post-coital bleeding in women that are usually greater than 65 or 60 years. And so the major treatment for this drug, for this disease condition, is actually surgery. Surgery is the definitive way. So you do a total abdominal hysterectomy with bilateral oophorectomy. That's like the definitive management, because there's no uterus, there's no cervix, basically. There won't be cervical cancer. So you do that for the patient. There's a vaccine you can give for young girls. Although it's step 2, you don't need to bother yourself so much. Just know that there's a vaccine. It's a vaccine preventable disease condition.
Or radiation. Radiation.
Radiation, yes. You can also use radiation as well. Okay. So, do we have any question at this point before I go further?
Can you explain the histology from the first aid book? Yeah. What does it mean, that resinoid nucleus and perinuclear halo?
So, what this resinoid nucleus means is that when you do a histology slide, it seems as if the nucleus is above the cell. So let me show you what that means, basically. Let me draw it for you so that you can have an idea. So the word resinoid just means what it just says, basically. So you have the cell. So this is how the thing looks like on histology, like when you're viewing it from above. So this is the cell. It's like the cell is beneath it, right? It's like the nucleus is above the cell. And then the other cytoplasmic contents tend to go very. So that's what you're just seeing. That's what just happens there. That's what leads to this perinuclear halo that you're seeing here. So around the nucleus, it seems as if the organelles or the cellular content tend to go towards the extreme around the nucleus, and it's as if the nucleus is kind of like upward. So it's like you're seeing it. If you're looking at it superior, it's like it's above the cytoplasm. That's what that resinoid nucleus means, right? I don't know if that makes sense to you.
Yes. Okay. Thank you.
Okay. So the invasive form is the main cervical cancer, and you diagnose it with colposcopy. So you do colposcopy, you do biopsy, try to get the level of it is. So this one basically can be classified according to the level of dysplasia. So basically, let me explain what this CIN mean basically. So let me explain it like this so that you guys can understand it. Right? So what you have here is that at CIN1, it arises from the basal cell of the transformation zone, this level here. And so CIN1 is that it's at the basal level here. CIN2, it gets to this second stage here. Maybe the next level, maybe the second part of it, maybe the second layer of the epithelium. So this cell kind of like goes above it, right? And then CIN3 is that it gets close to the basement membrane. So the cell gets to the basement membrane here, but it doesn't evade it. It doesn't pass through it. CIN1 is at the basement level. CIN2, it passes just a bit above the transformation zone. Maybe getting to the, what do you call it now? It's within the connective tissue here before it gets to the basement membrane. And then CIN3, it gets to the basement membrane, but it doesn't pass through it. Okay. But that's what
Wait,
you need to.
could you repeat what you just said? Which of the basement membrane are you talking about?
There's a basement membrane here. This is the BM. This is the basal layer of the transformation zone. So if it stays at this layer, it's CIN1.
Yes, even also when it's less than 1/3 of the tissues.
Yeah, you can use that. So that's also a very good point. But so let's use that. Let's say 1/3. So this is 1/3 of it. When you have 2/3 of the layer, it occupies. So it's getting to this point here. That's CIN2. So the cells are here. For CIN1, the cells are just here on this basal layer of the transformation zone. In CIN2, it takes about 2/3 of the cells. Yeah. So the cervical cell has like kind of like cells around all this side here before it gets to the basement membrane. This is transformation zone. There are a lot of cells here in between this space here. So if it takes 1/3 of the space, 1/3 of the space, that's CIN1. If it takes about 2/3 of the space, it occupies 2/3 of it. The cell is now, the tumor cells are not progressing. They have passed through the first layer of the cells. They are now at the second layer. So you're like kind of like dividing this space between the basal layer of the transformation zone and the basement membrane. You're dividing into three sections, basically. 1/3 of each, 1/3, 2/3, 3/3. So from the basal layer, the cells are there. If they remain in that basal layer, that's about 1/3 of the cells are affected. If they get to like this middle layer here, let's say the middle layer, I'm just estimating basically, this is more like 2/3 of the cells are affected. If it gets to this basement membrane here, that is about CIN3. But the problem with CIN3 is that it doesn't invade, so it just remains there. All the CIN are known as cervical intraepithelial neoplasm, basically. So they are also known as carcinoma in situ, right? So that's what I'm just trying to illustrate there.
Sorry, Dr. Ois.
Yeah.
There was a picture I saw in UWord.
Yeah.
That the basal layer is closely opposed to the basement membrane, and the epithelium is up So the growth of the
Okay,
tumor
goes upwards, downward.
grows from the basal layer to the epithelial layer up. The basement membrane, once it is pierced, then there is invasive cervical cancer.
Yeah, that's what I was trying to say. That's what I was just trying to illustrate here, basically. Okay, you are saying that the two of them are opposed together.
Yes, that the basement membrane is below the basal layer, not above the epithelial.
Okay, I'm kind of like confused though. Confused here. So you're saying that this is the basal layer, right?
It's
And then
down.
okay, the basal layer is down.
Yes.
This is the basal layer.
The basal layer, then followed by by the basement
Membrane.
brain.
So you're saying that it invades upward, downward like this. Is that what you're saying?
I don't know how I can share my screen so that you can see the U word.
The reward. Okay, just send me the image. Send me the image. Put it on the group. Just put it on the group. Yeah. Because me basically this how I kind of like remember it, but well, we learn every day. Okay.
Let's continue. I'll send it.
Okay. So we want to round off cervical cancer. So another thing you need to know about cervical cancer is that because of its location, it can invade the urethras. It can invade nearby structures. Not only that, it can block the urethra because the bladder is just anterior to the uterus. And so if you have a growth at the cervix, it can extend and kind of like obstruct the entrance of the urethra into the bladder. And that can cause hydronephrosis, and over time that can lead to heart failure, renal failure. They don't usually ask the cause of death. Yes, they do. They do actually. They actually do. I've seen an MBME question where they ask this: the cause of death in patients with cervical cancer. I think so. I saw renal failure in the options. You can check it. It's a long MBME that I answered. It's really a long time I answered that MBME. I can't really remember the exact year number, but you can check when you see it. So they tend to have renal failure, and sometimes it can lead to their death. Yeah. Okay. So we're going to talk about these guys here. Primary dysmenorrhea. This is very much easy. I think everybody has an idea of this, right? The endothelium is shedding off, and what the body tries to do is that it tries to minimize blood loss, and the uterus has a mechanism to do that. Even when a woman delivers a child, there's a mechanism that kind of like works to reduce that blood loss, especially in pregnant women. And the fact is this, that the fibers of the uterus run in a crisscross section. They run like this. So they run like this. And so the blood vessels are here. They are running this way. And so the other fibers of the uterus runs like this. I'm just giving an example, basically. I'm just trying to illustrate something, right? And so what happens is that the blood flow to the uterus comes from the adventitia. So for the adventitia to the myometrium and then the endometrium. So if I want to reduce blood loss in the endometrium, all I just have to do is to clamp the blood vessel at the myometrium. I just clamp it at the myometrium. This is the adventitia, this is the endometrium or the perimetrium or anyone. This is the perimetrium, the myometrium, and then the endometrium. This is the part that's being shed off. This is the part that is being shed off, right? This is the part that is being shed off. So if I want to reduce blood loss to this side, all I just have to do is it's just like a tap, right? You want to reduce the flow outside. All you just have to do is to twist this end here. If you twist this end here, the water stops coming out. So that's exactly what the uterus does. And so that contraction is what causes dysmenorrhea, right? That contraction is what causes dysmenorrhea. And what they usually ask you in the exam is what substance mediates it? What mediates the primary dysmenorrhea? And it's prostaglandins. That's what you guys should know for the steps. And so, because prostaglandins mediate the uterine contraction that happens, the very severe muscular contraction that happens in patients with dysmenorrhea, the drug of choice to treat it will be an NSAID. So anything that will stop the production of prostaglandins in that region there would help with primary dysmenorrhea. I don't know if that makes sense. So we're going to talk about the ovarian cysts, and I think we'll call it a day today. We'll call it a day today after the ovarian cyst. So there are 3 types of ovarian cysts, and the 3 cysts are kind of like physiological. I think 2 out of them are physiological. 1 of them is acquired. The physiological one is the follicular cyst, right? Follicular cyst is physiological. And then the corpus luteal cyst is corpus luteal cyst is also physiological. So the last one is the Tican Lucan cyst. So let me clean this so that you guys can see. So what's the pathophysiology in follicular cyst? So in follicular cyst, what happens is that you're supposed to have that cyst, like it's supposed to rupture basically. And a Graafian follicle is supposed to be formed. That Graafian follicle is supposed to rupture. And so it doesn't rupture basically. And so you have a follicular cyst. That's just the basic explanation to this. So in the follicular cyst, what you have is increased estrogen. So what they test in the exam is that they give you the presentation of a patient. The follicular cyst is the most common one. So they might give you a presentation of a patient who usually has pain before a period, and then she did an ultrasound scan that revealed a cyst measuring about so to so, and the diagnosis of follicular cyst is made. They now ask you which hormone is being secreted or is being produced by this cyst. So I want you to know for follicular cyst is the estrogen that's produced. The corpus luteal cyst basically is what basically happens. The follicular cyst has ruptured now, but we have the corpus luteum, and ideally the corpus luteum is supposed to degenerate. It's supposed to degenerate as time goes by, because basically the placenta is supposed to come and start and take over the supportive function to carry the pregnancy basically. But the corpus luteum does not degenerate and keeps producing progesterone. So failure of the corpus luteum cyst to involute is what causes the corpus luteal cyst. So progesterone. So increase in progesterone. So how do you know it's a corpus luteum cyst? You see an increase in progesterone level, right? When you see that, you should think of corpus luteal cyst. Now, this thecal cyst, basically, what you have here is that the patient, and this is what happens in patients that have excessive beta HCG. So the chemical or the hormone that is produced in this cyst is beta HCG. And this is the cyst that you find in patients with ovarian hyperstimulation syndrome. So when you see ovarian hyper, so how they put it in a question, let me just tell you how they put it in a question. So usually they will tell you guys that a woman has been trying to get pregnant, and then she went for maybe she went to see the gynecologist who infused her, who gave her a certain chemical hormone or something, and then she started having abdominal pain, started having pleural effusion, ascites, all those kind of things. And when they did an ultrasound scan, they saw that there was enlarged bilateral cyst. They usually ask you, what cyst is that? So usually the thecan lutein cyst, the thecan internal cyst is what you find there commonly. Okay, that's what you see basically, right? Another thing you need to know basically for the exam is that it's associated with GTD, all those GTD, gestational trophoblastic disease, is associated with it. Okay. All right. Do you have any questions so far? Okay, so your question. Okay, go ahead and ask your question. Let me answer it and then. Okay. So Dr. Nafia, you asked 2 questions. The first question. Okay, so let me answer your question, Dr. Nafia. I'll answer your question, Dr. Queen. So you're asking about middle cycle pain, right? How it differs from normal period pain. So the middle cycle pain kind of arises due to the fact that the Graafian follicle ruptures, and then some of those blood kind of like causes irritation of the peritoneum, right? Causes. Okay, so sorry guys, I think my my system went off. So let me try and explain that what do you call it? That middle cycle pain. So what basically happens in the middle cycle pain is that the follicular Graafian follicle ruptures. Can you guys hear me? What basically happens in that situation is that the the pain the pain is as a result of peritoneal irritation. But for the normal period, what you have is that the uterus is contracting, so the pain will be more frequent, and it will last for just 5, depending on when the woman feels is done with her period, right? So if her period is about 5 days, she will just feel the pain for this period and then it will stop. But for the middle cycle pain, she can almost predict when she would have that pain. And so this pain in particular is not more than a day, roughly just maybe a day or 2, and that's it. But for the normal period, she tends to have them for the duration of that time she has them, for the duration of when she has her period, basically. So that's the difference between both of them. And then you're talking about central and precarious puberty. I think I explained that thing in the last class. I was talking about, for central precarious puberty, the patient is having development of sexual secondary characteristics before the age of 8, and the cause of that is linked to a central cause. So it could be the hypothalamus is secreting too much of the hormones that is stimulating the gonads, right? It could be a hypothalamus issue, and hence in that situation it's different from the peripheral. The peripheral could be that the patient is having a peripheral issue, basically. So the patient is having a peripheral issue, meaning that there's something, the gonads on their own are secreting excessive excessive hormones that's leading to that, development of the secondary sexual characteristics. So that's basically the difference between both of them. I'm sorry, guys, my laptop went off, so I'm using my phone to kind of like finish it up. I didn't want to leave your question hanging. That's why I had to join with my phone. Okay. If there are any other questions, you can put them on the group. We're gonna answer them together. Dr. Raina, please can you put that picture so that I can see it?
It's already there. Check it.
Okay.
Check WhatsApp.
Okay, I'll check it now. Okay, so in the next class we'll address that picture together.
I have a little question with regards
Yeah,
to the corpus luteum you
yes,
talked
yes.
about. I didn't quite get the explanation you gave then,
Okay.
please.
Okay, so what I said was that what normally happens in the ovarian cycle is that every month there are follicles that are recruited. There are follicles that are recruited into to ripen so that it can produce to become it can now mature to become a Graafian follicle. A Graafian follicle is a matured follicular cell, and that Graafian follicle will have to rupture to release the eggs. The egg is the one that will not be fertilized by the sperm, and then pregnancy ensues. But what happens in the corpus luteum cyst is that after the Graafian follicle ruptures, it has done its job, it has ruptured. What happens is that the corpus luteum itself, the Graafian follicle, the remnant of that, after the egg has been released, the remnant of that Graafian follicle is the corpus luteum. That corpus luteum is supposed to degenerate if there is no pregnancy. It's supposed to degenerate, right? It's supposed to degenerate if there's no fertilization, if there's no pregnancy. But what happens in corpus luteum cyst is that that corpus luteum that's supposed to degenerate does not degenerate. So it stays on. It continues to stay on. And if it continues to stay on, the patient will have corpus luteum cyst. That's basically what just happens. And of course, the corpus luteum produces progesterone in anticipation that fertilization would occur so that the placenta can take over the pregnancy, right? But because it does not generate, the patient will keep having a very high level of progesterone. So what just basically happens, the simple thing I just want you to understand for corpus luteum cyst is that the corpus luteum, which is the remnant, a byproduct of the rupture of the Graafian follicle, does not involute. That's just the simple thing. You understand? It does not involute. It becomes cystic. It does not involute. It's supposed to involute. It's supposed to undergo apoptosis and involute, but it doesn't do that. Hence, the patient will have a corpus luteum cyst. So that's just basically what happens.
And then, sorry, one last question. You said when you started talking about the cyst, you said we have the physiological and acquired, and then you
Yes.
mentioned the follicular and the corpus luteum, and you said both
Yeah.
of them were
Physiological.
physiological. But I
Yeah. Yeah.
didn't hear you talk about the acquired ones. So do you plan
The
on talking
acquired,
about them in the next class?
the acquired one is the Tecan lutein cyst, and that's what I was trying to
Okay.
explain. Yeah, I
Okay
was
then.
trying to explain that the Tecan internal cyst or the Tecan lutein cyst is actually produced as a result of ovarian hyperstimulation syndrome. So what basically happens is that you are trying to get a woman pregnant, and then you infuse a very large amount of beta HCG into the woman. Do you understand what I'm trying to say? And what that does is that that's kind of like, okay, yeah. So that kind of like causes the Tika interna to kind of like proliferate and become cystic. So that's what just basically happens there.
Thank you.
Mm. Okay. Do we have any other more question? I'm sorry, guys. I think I was rounding up, or I already round up when my system actually just went off. So let me allow you guys to join your UWorld session. Doctor, somebody asked about materials to prepare for step one. First aid is what I usually recommend. First aid, UWorld. What else will I say? There are some videos you can watch that will help you for biostatistics and ethics. You can also use Randy Neal. He's very good. UWorld is very helpful. And do your MBMEs. But first aid is the book that I would recommend. There are also another book you can use. I used it when I was also preparing for my step one. It's called Crush Step One. I think have I put that in on the group? I'm not sure. I'll put it on the group. It's also very, very helpful. But first aid, 90% of the questions you're going to see that day, I can bet you, is from first aid. If you read first aid, you're more than okay. And that's why I actually recommend the book a lot. Okay, so in the absence of any other question, I'd like you guys to do your U-Word session. And take care, guys.
Thank you very much.
Yeah.